Bismillahirrahmanirrahim. Start with the greatest name of Almighty Allah, most gracious and merciful, whose bounties are unbounded, whose benevolence is everlasting, whose blessings are uncountable, whose being is eternal, whose mercy is unlimited, whose provisions are unending, and whose love is all life, whose worship is all faith. So let's start. Lecture number 34. Dear students, today we will discuss about the nicotinic receptors and how we can differentiate between different type of nicotinic receptors, NM and NNs. So look at here, NM is muscle types and the NN is ganglion type. So the nicotinic receptors are actually differentiates. It can be categorized into two categories. One is the muscle type and the second one is ganglion type. So the muscle type or nicotinic receptor muscle type, they are anatomically, so they are present and the skeletal muscles at the end plates. Its function is to stimulate the skeletal muscle contractions. The mode of action or mechanism of action of these kinds of muscle type of nicotinic receptor, actually they can directly turn post-synaptic and excitatory. So it means that it can increase the sodium and potassium permeability. Drug may be agonist or drug may be antagonist. So actually agonist, for example, acetylcholine, carbachol, and 6-oxamethonium selective stimulation by penyl trimethyl ammoniums, while antagonists are tubocurarins, atracuriums, and vancuriniums and pincuriniums. While the ganglion types, they are anatomically, so they are present in the autonomic ganglia of all types ganglion types. They are sympathetic, parasympathetic, and also adrenal medulla. The function of ganglion type nicotinic receptors, it may cause depolarization and post-ganglionic impulses. It stimulates all the autonomic ganglia. Its simple mode of actions, mechanism of action is they are excitatory in nature, and they are excitatory in natures, especially the sodium ion, potassium ion, and the calcium channels, so it becomes opens. So it means that the actually this type of receptor, they are excitatory in nature and they can cause the opening of the sodium, potassium and calcium channels which are mentioned here. The drugs which come under the category of the ganglionic type, that is acetylcholine and CCHA nicotine, selectively they are stimulated by the dimethylphenyl piperaziniums, while the antagonists are trimethopons and mecamylamines and hexamethoniums. The cholinergic drugs are chorinomimetics or parasympathomimetics. These are the drugs producing the action similar to acetylcholine by interacting with the cholinergic receptor or increasing the availability of acetylcholine at these sites. Look at here. What side effects might you expect to see in a patient taking cholinergic drugs? Hint. Cholinergic is a Greek word meaning cholons and urgents. So the classification of direct acting receptor agonist, choline ester, natural acetylcholine, and synthetic is methacholine and carbacols and beta-nicols. While the alkaloids, these are the special group, pilocarpine, muscarines and ericholine, these come under the category of alkaloids, while the synthetic drugs are oxytrimurines. The cholinergic drugs, which are indirect acting drug, that is anticholinergic. So cholinesterase inhibitor are reversible anticholinesterase. If you remember, we have already talked about all the things which is related to the cholinesterase inhibitors. So the natural cholinesterase inhibitor is Physostigmine, while the synthetic one is neostigmine, pyridostigmine and destigmine, rivastigmine and donepezils, galantamines and eudroponiums and embinoniums and dimicariums. The irreversible anticholinesterase, these are organophosphorus compounds, that is called OPC, while diisopropyl fluorophosphate DFE, while the ecothiopates and parathione, malathiones, dizenones and insecticides, and these are pesticides. Tabun, serines and so on, these are the nerve gases and wards. The carbamate ester, that is called carbaryls and profoxers, bigans. Acetylcholine action, they are muscarinic in nature, so look at how repolarization is occurred, polarization is occurred. So look at the heart. As we know that the receptor which are present in heart, that is M2 receptor. As we know that the SA node sinoarterial node, it may cause hyperpolarization. So what is hyperpolarization? Hyperpolarization means decrease in the rate of diastolic depolarization, reduction in the impulses generation in bradycardia may be occurs. AVN and PF, RF is increase, atrioventriculars hyperpolarizations, and you can say the slowing of contraction and partial complete heart, it become blocked. Atrial fiber, reduction in the force of contraction and the especially in the RP and the fibers abbreviated, which is already mentioned here. Atrial fibrillation and flutters, the non-uniform vagal innervation and variety in the intensity of effect on RP is different and different atrial fibers. Decrease in ventricular contractility, and which is less prominent. As we know that the blood vessel, it contains M3 receptor, muscarinic receptors. The cholinergic innervation is limited, the skin of the face and neck. But M3, they are present in all type of blood vessel vasodilatation by nitric oxides, which release and fall in blood pressure, and flushing and penile erections may be occurs. Muscarinic, these are nicotinic, these are also muscarinic actions. Other muscarinic action are smooth muscles. So as we know that M3, these are the receptor which are present in the smooth muscles, all are contracted. The abdominal cramps, diarrhea may occur due to increased peristalsis and relaxed the sphincters. Widening of bladders, bronchial smooth contraction, dyspnea, take up the asthma, etc. The glands M3 increase the secretion, sweating and salivations, lacrimation and tracheobrachial tree and gastric glands. The pancreatics, the pancreatic and intestinal glands, they are less prominent, while the receptor which are present, that is M3 receptor, so it cause contraction of the circular fibers of the iris, especially it cause miosis, contraction of the size, especially of the iris, and the contraction of the ciliary muscle. So the ciliary muscle, it also become contract. So this is very easy to understand. The contraction of ciliary muscle, spasm of accommodations, while increased outflow and reduction in the intraocular pressure. Acetylcholine action, it may be nicotinics, especially in the autonomic ganglia. So both sympathetic and parasympathetic ganglia are stimulated. After atropine injection, acetylcholine causes tachycardia. So the heart rate become increased after administration of atropine injection, and it will rise the blood pressure. Now, what are the effects of nicotine receptor on the, especially on the skeletal muscle? If they are injected in the form of injections or IV injection, there will be no effect, but application may cause contraction of the skeletal muscles. Now the effect which are seen after administrations of the acetylcholine. So in central nervous system, it doesn't penetrate the blood-brain barrier. So local injection in the central nervous system complex section may cause acetylcholine. It is not used therapeutically. This is non-specific like beta-nicole. So beta-nicole uses their post-operative and postpartum urinary obstructions, neurogenic bladder and GERD, gastroesophageal reflux disease, 10 to 40 milligram oral. It can be recommended to the patients. Now come toward another drug that is called Pilocarpine. You know, Pilocarpine is actually alkaloid which is obtained from the leaves of jaburendi. So look at, this is the name of the plant, and actually the alkaloids, the drugs which are extracted from the jaburendi, that is called Pilocarpus microphallus. This is a prominent muscarinic action. It cause prominent muscarinic action. Profuse salivation may be occur, lacrimation may be occurred, sweating may be occur, and when pilocarpine they are administered, so it can dilate the blood vessels, it cause hypotension, it can directly low down your blood pressure. Pilocarpine can be given in high doses. If pilocarpine is given in the high doses, so it can rise the blood pressure and tachycardia, it can increase the heart rate, ganglionic action, especially on eyes. These pilocarpine, if they are administered especially in eyes and ophthalmic administration, so it will produce miosis. It means miosis and spasm of the accommodation. Miosis means reduction of the size of the people, are, you can say, errors, and lowers intraocular pressure in glaucoma when applied is eye drops. So too toxic for systemic use, especially sinus toxicity, central nervous system toxicity, and diuretic action, xerostomia, and many and more syndromes, so it can be seen here. Now the clinical uses of pilocarpine. So as we know that pilocarpine, it is used as eye drops in the treatment of wide angle glaucoma, which is the eye disease. For what purpose? In order to reduce the intraocular pressure, to reverse the mydriatic effect of atropines. Actually this pilocarpine, when they are given to the patients in the form of eye drops, so it is used in the treatment of glaucoma because it can reduce the intraocular pressure. To break the adhesion between the iris and cornea lens, it can alternated with the mydriatic actions. As we know that pilocarpine nitrate eye drops 1 to 4%. Atropine used as an antidote in acute pilocarpine poisoning. Let's suppose a pilocarpine overdosing has occurred, then atropine can be recommended. Atropine is an antidote which can reduce the toxicity or the toxic effect of the pilocarpine. So atropine is used as an antidote, as a counter agent, especially in acute pilocarpine poisonings at the dose of 1 to 2 milligram intravascular, so especially 8 hourly, after 8 hours. Pilocarpine, the clinical indication of pilocarpine, they are also used in the treatment of glaucoma, which is the eye disease and constriction of the circular muscles, the muscles of the iris, so it become constricts. The contraction of the ciliary muscles occurs, spasm of accommodation, fixed at near visions. Another one is muscarine. So muscarine is the alkaloid which is obtained from the mushroom Amanita muscaria. So only muscarinic actions, no clinical use. The mushroom poisoning due to ingestion of poisonous mushroom, early onset mushroom poisoning, they are muscarinic type, but later on onset of mushroom poisonings, hallucinogenic type. So all these are related to here. Mushroom poisoning, early onset mushroom poisoning is occur 1 by 2 to 1 hours. Symptoms are characteristics of the muscarinic actions. Anisib or cletosib, severe cholinergic symptoms like vomiting, salivation, lacrimation, headache, bronchospasm, diarrhea, bradycardia, dyspnea, and hypertensions. Mean bradycardia mean decrease in heart rate, dyspnea mean difficulty in respiration, hypertension, weakness and cardiac collapse may be occurred, convulsion and coma may be occurred. Antidote is atropine, which I have already mentioned there. So antidote is atropine sulfate, can be given at a dose of 2 to 3 milligram intramuscularly every hourly until improvement. Hallucinogenic type due to macimoles or abutanic acid present in the especially in the Amanita muscarica. So they are present in the muscarina. It can block the muscarinic receptor in the brains and it can activate the amino acid receptor. There is no specific treatment, so atropine is contraindicated, while the late onset mushroom poisoning is occur within 6 to 15 hours. Amanita phyllites, deadly nightcap due to peptide toxin. It can inhibit the ribonucleic acid polymerase 2 and therefore messenger RNA synthesis take place. Irritability may be occurred. These are the side effects which are reported. Restlessness, nausea, vomiting, bloody diarrhea, ataxia, involuntary shaking, hallucination, delirium, sedation, drowsiness, sleep, and kidney, liver, anxiety, mucosal damage may be occur. It can also maintain the blood pressure, respiration. Injection diazepams can be given at 5 mg intramuscularly. Atropine is contraindicated as it may cause convulsion and death. Penicillin, thiactic acid, and silibinin antidote. So gastric lavage and activated charcoal, they are used. Cholinergic drug, they are indirect acting as cholinesterase inhibitor or reverse anticholinesterase that are natural, which I have already mentioned in my previous lectures. So the natural is physostigmine, the synthetic one is neostigmine and pyridostigmine, destigmine and rivastigmine, and many more. The tertiary amine N lipid soluble and quaternary N lipid N soluble. So the irreversible anticholinesterase enzyme, which I have already explained this slide in the previous lecture. Organophosphorus compound OPC, diisopropyl, fluorophosphate, and ecothiophates, parathione and malathione, and many and more drugs they are used. Mode of action or mechanism of action of acetylcholine. So normally we know that acetylcholinesterase, it is the name of the enzyme which cause hydrolysis breakdown of acetylcholine, and the active sites of acetylcholinesterase is made up of two subsites. One is anionic and the second one is stearic. The anionic sites serve to bind a molecule of acetylcholine to the enzyme. Once the acetylcholine is bound, the hydrolytic reaction occurs at the second region of the active sites, which are already mentioned here in its medicinal chemistry. So the second region of the active site is called a stearic subsite. The acetylcholine enzyme itself gets acetylated at the serine site, while acetylated enzymes, they can react with water and the acetic acid and choline they are formed. Choline is immediately taken up again by the high affinity choline uptake system, presynaptic membranes. Moreover, the anticholinesterase also act with the enzyme acetylcholinesterase in similar fashion like acetylcholine, while the carbamates actually the carbamylates, the active sites of the enzyme. Carbamates, these are the agents, these are the drugs, and carbamylates, the active sites of the enzyme, and the actually the phosphates, which are called phosphorylate enzymes. Both react similar fashion covalently with serine, and carbamylated reversible inhibitor react with water slowly, and the stearic site is freed and ready for the action. So almost it will take 30 minutes, less than synthesis of fresh enzyme. But phosphorylated irreversibly, so they can react with extremely slow or not at all, so take more than time than the synthesis of fresh enzyme. So sometimes the phosphorylated enzyme loses one alkyl group and become resistant to the hydrolysis, that is called aging. Adroponium and tecrine react especially only at the anionic site. One is cationic site, one is anionic site. So actually this is short acting, while organophosphate react only at the stearic sites. Anticholinesterase is actually the individual drugs. There are two important clinically used drugs in cholinesterase, that is called physostigmine, which is lipid soluble and it can cross the blood-brain barrier. The ganglion acting and less action in the skeletal muscle, all the organophosphates. while the neostigmine is lipid insoluble. They are not solubilized in lipid, so skeletal, they can directly act on the skeletal muscles. As we know that Physostigmine, it is another anticholinergic drug. So Physostigmine is alkaloid, which is obtained from the dried ripe seed caliber beans of the African plant Physostigma venenosum. This is the name of the plant where the Physostigmine is extracted. The tertiary amine, lipid soluble, well absorbed orally and cross the blood-brain barrier. It can be hydrolyzed in the liver and plasma by esterases. Long lasting action 4 to 8 hours. It indirectly prevents the destruction of acetylcholine arising from the cholinergic nerve ending and causes acetylcholine's accumulation, deposition. A muscarinic action on the eye causing myiasis and spasm of the accommodation on the local application. Salivation, lacrimation may be occur, sweating, increase in the trachobronchial secretion, as well as it also increase the heart rate and hypertension may be occur. These are the side effects which were reported. While the Physostigmine, the clinical uses of Physostigmine, they are used as a miotic drops to decrease the intraocular pressure in the eye, especially in case of glaucoma, to antagonize the mydriatic effect of atropine, to break the adhesion between the iris and cornea, and alternating with the mydriatic drops. Belladonna, deadly nightshade poisoning, tricyclic antidepressant, and phenothiazine poisonings may be occur. Alzheimer's disease, presenile or senile dementia, memory lapses. Atropine is antidote and Physostigmine poisoning. ADR, these are the adverse drug reaction which are repeated CNS stimulation followed by the depression. Neostigmine, this is another agent which is called synthetic reversible anticholinesterase drug, which is also called quaternary ammonium compound and lipid insoluble. It cannot cross the blood-brain barrier. They are hydrolyzed by the esterases enzyme in the liver and plasma. The short duration, its duration of action is very short, that is almost 3 to 5 hours. Its direct action on the nicotinic receptor is present in the neuromuscular junction, motor and plate of skeletal muscles. It can also antagonize the reverse skeletal muscle relaxation, which causes paralysis and caused by the tuberculins and other competitive neuromuscular blocking agents. It can also stimulate the autonomic ganglion. Small doses, large doses block the ganglionic transmission. No CNS effect may be occurs. The neostigmine, the clinical uses of neostigmine and its adverse drug reaction, they are reported by different literature. So they are used in the treatment of myasthenia gravis to increase the muscle strength. So they also mean it can enhance, it can increase your muscle strength. So it is also used in the post-operative reversal of neuromuscular blockage, and it is also used in post-operative complication like gastric atony, paralytic ileus, urinary bladder atony. Cobra, it is also used in the treatment of cobra snake bite. Neostigmine, this is very effective in the treatment of cobra snake bite. They are used against this condition. So it also produces stretching and fasciculation of the muscle leading to weakness. Atropine is the antidote in acute neostigmine poisonings. Now come to the differentiation between Physostigmine and neostigmines. So Physostigmine and neostigmine, these are the sources which are given here in the table. The basic chemistry, oral absorption, CNS action, eye effect, uses, dose and duration of action. So Physostigmine, they are naturally, so its source is natural, and the neostigmine, this is synthetic one. Look at its chemistry. So Physostigmine actually it is tertiary amines compounds, while the neostigmine is quaternary ammonium compound. Physostigmine, it can be its oral absorption is good, while the oral absorption of neostigmine is poor. And CNS action Physostigmine, so they can directly act on the central nervous system, while they do not, neostigmine do not show any reaction on the central nervous system. and eye. So physostigmine, it can penetrate the cornea, while the neostigmine, it doesn't penetrate. It is poor penetration to the cornea. It means its effect on the eye is slow as compared to the physostigmine. Physostigmine, it can produce the myotic actions, and actually neostigmine, they cause especially myasthenia gravis, while the physostigmine, the dose which is recommended, especially the treatment or the dose of physostigmine is 0.5 to 1 milligram oral or parenterals, and 0.1 to 1% eye drops, while the neostigmine is its dose is 0.5 to 2.5 milligram, and from muscularly or subcutaneously one is 15 to 30 milligram orally, and duration of action is 4 to 6 hours and 3 to 4 hours. So the physostigmine, its duration of action is 4 to 6 hours, while the neostigmine, its duration of action is 3 to 4 hours. Duration of action mean that in which time period the drug started was. Now thank you so much for watching my lecture. Inshallah, in my next lectures I will talk about the myasthenia gravis, what is myasthenia gravis and how it can be treated. Thank you.